Hi everyone, I'm Dr. Bojarian from Division of Endocrinology at Westchester Medical Center. Thank you for joining today. Today we are going to explore beyond hormones, key determinants of calcium metabolism, looking at the multiple factors, genetic, renal, dietary, and pathological that govern calcium balance in the body. By the end of this session, my goal is for you to not only understand the classic hormonal pathways, but also recognize the broader clinical and physiological determinants that can impact calcium levels in your patient. And these are my learning objectives. So, regarding the physiology, we can't understand calcium disorders without first knowing the physiology. Calcium, phosphate, and PTH interact through tightly regulated pathways involving the gut, kidneys, and bone. So, a quick review of their normal control is essential before tackling the abnormalities. Calcium regulation involves four key organs, the skeleton, kidneys, intestine, and parathyroid glands. When extracellular ionized calcium drops, calcium sensing receptors on parathyroid cells detect the change and trigger PTH release. Regarding the actions of PTH on bone, PTH rapidly stimulates osteoclastic bone resorption and can cause releasing calcium and phosphate into bloodstream. Just remember, releasing calcium and phosphate both together. On kidneys, increases calcium reabsorption, decreases phosphate reabsorption, and it stimulates 1-alpha hydroxylase. So in order to convert 25 vitamin D into active form of vitamin D, which is calcitriol or 1,25 dihydroxy vitamin D. And what does 125 dihydroxy vitamin D do? As you can see in the picture, can increases intestinal absorption of calcium and phosphate, enhances also classic bone resorption, provides feedback inhibition by suppressing 1-alpha hydroxylase, which actually decrease the level of 125 dihydroxy vitamin D and 25 vitamin D. And also can raises FGF23. We will talk more about FGF23, which promotes phosphate exertion, suppresses 125 dihydroxy vitamin D production, and reduces PTH secretion. And overall effect, calcium and phosphate are mobilized from bone and absorbed from the intestine, but the kidney retains calcium and excretes excess phosphate. Serum calcium normalizes, phosphate remains stable, and PTH secretion decreases. So just a quick review regarding the location of calcium sensing receptors. They're located primarily on parathyroid gland and on the surface of parathyroid chief cells. This is the most important site. Also, during the kidneys, especially in the thick ascending limb of the loop of Henle, also present the distal convoluted tubule. So calcium sensing receptors in parathyroid gland, they detect changes in extracellular ionized calcium and regulate PTH secretion. And also in kidneys, they help regulate calcium reabsorption and control urinary calcium excretion. Okay. So this slide is about physiology and about the non-hormonal regulators of calcium. So calcium metabolism is influenced not only by hormones, which like a PTH, but also by several non-hormonal factors. For example, vitamin D. Regarding vitamin D status, vitamin D initially comes from sunlight and diet. Regarding the sunlight, UVB converts 7 the hydrocholesterol, or for ease, we can just say 7-DHC into skin, into vitamin D3 or cholecalciferol. Both dietary D2 and D3 are converted in the liver to 25 hydroxy vitamin D, then in the kidney to the active form of vitamin D, which is 125 dihydroxy vitamin D. So in terms of vitamin D versus vitamin D3, vitamin D2 or ergocalciferol mainly comes from plant sources, mushrooms, for example, and D3 or cholecalciferol produced in the skin found in animal sources like fatty fish, egg, and what are the differences? They have a slightly different chemical side chains. D3 is better absorbed, more stable, and more effectively converted to active vitamin D. So it is preferred in supplements. And other non-hormonal regulators are dietary calcium and phosphate intake, and some products like oxalate or phytate, they actually they inhibit absorption of calcium. And in terms of renal function, any kind of like a kidney impairment can alter phosphate handling. Also can change FGF23 signaling pathway as well. Medications like loop diuretics, tyroside, bisphosphonate can change calcium balance in our body and also acid-base balance as well. We'll talk about the effect of acid um, in future slides. I would like to talk about the effect of FGF23 on phosphate and calcium a little more. We have like a protein named alpha koto. So alpha koto and fibroblast growth factor 23 are two key hormones that function together to regulate phosphate and vitamin D metabolism. FGF23 basically is a hormone produced primarily in osteocytes and osteoblasts in the bone. And its main function is to lower serum phosphate level and regulate vitamin D production. We call FGF23 it's like a phosphaturic agent. And what is alpha koto is basically a transmembrane protein highly expressed in kidneys and parathyroid glands, and it is essential for FGF23 to bind with high affinity to its receptor, which is fibroblast growth factor receptors. So high phosphate or high vitamin D levels stimulate the production and secretion of FGF23 from the bone, and circulating FGF23 travels to the kidneys, and with the help of membrane alpha koto as a co-receptor activates signaling pathway. And this signaling leads to decreased renal phosphate reabsorption, decreased production of active vitamin D or calcitriol by suppressing 1-alpha hydroxylase enzyme. And also the overall effect is a reduction in serum phosphate and vitamin D level, maintaining mineral balance. And why is this important to us? Because we do have genetic abnormalities called hypophosphatemic rickets. And in this genetic disorder, we do have gain of function of FGF23, a gain of function mutation. And so means that we do have a lot of FGF23 hanging around and can cause very low phosphate level, and we call it phosphate wasting disease. And so because of very low phosphate can impair bone mineralization. Okay. So it's important to know that calcium in the blood exists in three forms. About 40 to 45% bound to proteins, mainly albumin. About 15% bound to anion such as phosphate or citrate, and about 40 to 45% as free ionized calcium. So this free ionized calcium is biologically active form, and most labs report total serum calcium, not the ionized calcium. And also regarding the effect of, regarding the effect of blood pH to ionized calcium and total calcium. Basically, hydrogen ion competes with calcium for a protein binding sites. Okay, and what does it mean? Means that If someone has low pH or acidosis, it means that fewer bonding sites and can increase ionized calcium. And if someone has alkalosis or high pH, we do have more binding sites, means that lower ionized calcium and lower active form of calcium. Also, as I mentioned, about 40% of calcium in the blood is bound to albumin. And when albumin is low, or the situation that we call it hypoalbuminemia, for example, in setting of chronic disease or malnutrition, so we do have that the total calcium appears low, even if the biological active ionized calcium is normal. And if we do have too much albumin hanging around, for example, in a case of severe dehydration or diseases like multiple myeloma, we have like a more albumin, and means that decrease in the serum total calcium concentration, but if, without any rise in the serum ionized calcium concentration. So it's important always to report corrected calcium, not only calcium, but also corrected calcium when you want to check for hypo or hypocalcemia. You can use this formula to just have an idea what is your corrected calcium. So always make sure that you order albumin or CMP when you are following calcium level in your patient, either hypercalcemic or hypocalcemic. Make sure that you have albumin, the level of albumin, and then you can use this formula to have corrected calcium level. Okay, so let's talk about causes of hypocalcemia. So we can have like a three different categories regarding causes of hypocalcemia. So we can have PTH defects. In this category, we can have absent parathyroid gland, for example, the setting of surgery. We'll talk about like each of them in the next slides. We can have deficient synthesis of parathyroid hormone, deficient secretion of parathyroid hormone, high or low magnesium, bioinactive parathyroid hormone, or parathyroid resistance. In category of vitamin D defects, we can have deficient vitamin D supply, we can have defect in activation of vitamin D, and deficient vitamin D action. Also, other disorders like Heinrich-Owen syndromes can cause hypocalcemia, pancreatitis, sepsis, hyperphos, and calcium deficiency diet also can cause hypocalcemia as well. So I would like to talk about the magnesium. So both high and low magnesium levels can decrease PTH secretions, and low magnesium is like we call it less than 0.8 milliequivalent per liter. And severe low magnesium impairs PTH gland function, effectively, basically can paralyze PTH secretion. And common causes of hypomagnesemia is malabsorption, chronic alcoholism, and prolonged parenteral fluids also can cause hypomagnesemia as well. Also, on the other hand, high magnesium means that any level more than 5 milliequivalent per liter can basically activates the calcium sensing receptor and falses signaling high calcium levels. So this suppresses PTH release, causing hypocalcemia. So it's important. We do not usually see hypermagnesemia, but in one situation we do see hypermagnesemia, and this is in the setting of preeclampsia, like a pregnant women receiving magnesium sulfate for preeclampsia, and in this situation, sometimes we do see hypermagnesemia, and as a result, hypocalcemia. So make sure that you always take a look at the magnesium when you're dealing with a patient with hypocalcemia. So regarding vitamin D action, Vitamin D works not just by circulating in the blood, but by binding to a specific nuclear receptor inside target cells. This receptor is called vitamin D receptor and is encoded by the VDR gene or vitamin D receptor gene. And what activates VDR or vitamin D receptor? So the strong activators of vitamin D receptor is 125 dihydroxy vitamin D or calcitriol. And it's really important to know that 25 hydroxy vitamin D is not uh, like a strong activator of vitamin D receptor. And a strong activator is basically 125 dihydroxy vitamin D. This is a biologically active form, and because it can bind the receptor with high affinity. Other form of vitamin D, as I said, bind VDR poorly, which is that's why the body requires activation in the kidney first. And if you remember, the enzyme to activate 25 hydroxy vitamin D to 125 dihydroxy was 1-alpha hydroxylase. And what type of receptor is VDR? So the VDR is a nuclear receptor, meaning it sits inside the cell and basically in the nucleus, and it works like transcription factor. It only becomes active when its ligand basically 125 dihydroxy vitamin D binds to it. And this receptor belongs to the same receptor family as the steroid hormone receptors and thyroid hormone receptors, and which basically sharing structural similarities. And what happens when vitamin D binds its receptor, as you can see here, when 125 dihydroxy vitamin D binds receptor, VDR pairs with another nuclear receptor, and these complex attach to a specific DNA sequence, and that complex regulates transcription of numerous genes. This results in increased calcium and phosphate absorption in the intestine, increased bone mineralization, and decreased PTH production. And what does deficient vitamin D action mean? So exactly the opposite of the action that I just discussed. So vitamin D deficiency can occur at several levels. We can have low vitamin D through like a low vitamin D through diet or sunlight. Failure to activate vitamin D means that any problem in kidneys or liver disease, especially in like a CKD patient, that they do not have enough 1-alpha hydroxylase, and the patient cannot produce enough calcitriol or active form of vitamin D. Also, we can have some genetic disorders that you have defective VDR or defective vitamin D receptors. In this disease, we do have vitamin D dependent rickets type 2. We can have resistance at the tissue level, and so even if vitamin D levels are normal, we have VDR malfunction or reduced expression, which can lead to impaired calcium absorption and secondary hyperparathyroidism and weak bone, rickets, or osteomalacia. Okay. Regarding the let me see. Let me skip some. Okay, so we discussed about this, and then about the hypoparathyroidism, about the causes of hypoparathyroidism. So just want to show you. Okay, we discussed about the PTH. We discussed about the magnesium and also about the vitamin D defects, and also, as I said, we can have a parathyroid hormone problem as well. And now I want to and just talk a little more about causes of hypoparathyroidism that can lead to hypocalcemia. So we can have transient hypoparathyroidism. We can say the newborns of mothers with uncontrolled diabetes or maternal hypocalcemia. And also we can see this transient hypoparathyroidism in premature infants as well. As I said, any change in magnesium levels can impair PTH, can cause impairment in PTH secretion and can cause hypoparathyroidism. Some genetic disorders like DiGeorge syndrome can cause it. Also, some like a genetic mutation in calcium sensing receptor, parathyroid hormone, can cause hypoparathyroidism. And we do have resistant to parathyroid hormone. In this category, we have Alport hereditary osteodystrophy, and we do have pseudo hypoparathyroidism as well, and pseudo hypoparathyroidism. In terms of like autoimmune diseases, the most like a famous one is autoimmune endocrine syndrome type 1 or APS type 1. In this syndrome, we do have hypoparathyroidism, adrenal insufficiency, and mucocutaneous candidiasis. And you can remember as a class A trial like HAM or HAM. The gene is AR gene, ARRE, and if we have a mutation in this like a gene, we can have APS type 1 or autoimmune polyendocrine syndrome type 1. Also, we can have parathyroid infiltration in the setting of granulomatosis disease, iron overload, Wilson disease, or metastatic tumor. Also, in HIV patients, in HIV infection, we can have low secretion of parathyroid hormone. The most common cause basically is iatrogenic or post-surgical. If someone goes for any like a kind of neck surgery, especially thyroidectomy, unfortunately, sometimes we do see hypoparathyroidism after that. And any kind of radiation, chemotherapy, or thyroid ablation as a side effect can cause hypoparathyroidism. And hungry bone syndrome, especially after severe primary hyperparathyroidism after surgery, we can see hypocalcemia because of rapid bone mineralization and also hypoparathyroidism, which both can cause hypocalcemia, which actually is very severe. Okay, so we so far learned about causes of hypocalcemia, and now we want to talk about clinical manifestations of hypocalcemia. So it really depends if your patient develop hypocalcemia like acutely or chronically, and also the rate of development is important. So in terms of acute manifestations, we can see tetany, papilledema, and seizures. And chronic manifestations, we usually see ectodermal and dental changes, cataract, basal ganglia calcification, and extrapyramidal disorders. Again, this is like a more chemical manifestations for hypocalcemia. Again, for like acutely, if your patient develop acutely, we can have neuromuscular irritability or tetany, paresthesia, muscle twitching, carpal tunnel spasm, and chronically you can have Parkinsonism, ectopic calcification, dry skin, so on and so forth. Okay, so it's important to understand those signs. We have Trousseau sign, which basically is carpal spasm induced by inflating a blood pressure cuff on the arm. And we do have Shavasana sign, which is facial muscle twitching in response to tapping the facial nerve. And it's really important to make sure that you order EKG for your patient with hypocalcemia, and you will see prolonged QT interval. Just as a reminder, the normal QT interval is less than or equal to 0.44 seconds. It's important to check EKG and order EKG to just make sure that your patient will not develop prolonged QT interval. Okay, and how about radiological features of vitamin D deficiency? We can have rickets in kids and assimilation in adults. They do have bone pain and deformity, pseudofractures and looser zones, muscle weakness, and when severe can cause hypocalcemia. And you can see looser zone here. And this condition basically named after Swiss surgeon Emil Lusser, and is also described in the literature as milkman lines, cortical infarction, and pseudofracture or insufficiency fracture. Lusser zones represent unmineralized osteoid deposition at sites of stress or along nutrient vessels. So about the milkman is actually named after Louis Arthur Milkman, an American radiologist who described this finding in 1930 and 1934. Okay, and those are more radiological features. Characteristic signs at the growth plate or metaphysis. You can see widening of the growth plate, cupping of the metaphysis, a fraying of the metaphysis, which is basically irregular fuzzy metaphyseal border. As you can see, we have a splaying or flared metaphysis, which is widening and outward flaring of the metaphysis. You can see a bowing of the long bones, especially tibia and femur. And chest finding, as you can see here, we have a rachitic rosary on X-ray, which is characterized by bead-like swellings at the junction of the ribs and cartilage in the chest. It is caused by deficiency of vitamin D and calcium, severe deficiency of vitamin D and calcium, which leads to impaired bone mineralization and results in the overgrowth of cartilage at the costal condyle junctions. Okay. Okay, regarding the treatment of hypocalcemia, just quick review of treatment. Always ask yourself if your patient has carpopedal spasm, laryngospasm, bronchospasm, or seizures, if your patient has prolonged QT interval, or if your patient has acute decrease in serum corrected calcium to less than or equal to 7.5 milligram per deciliter. Why these criteria are important? Because we tend to treat with IV calcium, not the calcium injection, it's the IV calcium. But if your patient does not have any of those criteria that I just mentioned, you can basically manage with high dose oral calcium. And always make sure that you correct hypomagnesemia at the same time, because if your patient has severe low magnesium level, it's really difficult to correct calcium. Also, if your patient has hypoparathyroidism or a kidney dysfunction, you have to give your patient active form of vitamin D and oral calcium. Because if your patient does not have parathyroid hormone, basically the enzyme 1-alpha hydroxylase is not going to work. And just as a reminder, what does 1-alpha hydroxylase do? 1-alpha hydroxylase going to convert 25-hydroxy vitamin D to active form of vitamin D, which is 1,25-dihydroxy vitamin D. And this active form of vitamin D actually can regulate calcium level in our body. So if your patient doesn't have parathyroid hormone, basically 1-alpha hydroxylase enzyme cannot be activated, and we need to give patient calcitriol from outside. Okay, just a quick take-home messages. A corrected calcium usually calcium level less than 8.5 milligram per deciliter, but it's can be a little like a different from assay to assay. And always make sure that if you have hypocalcemia, always make sure that you order PTH. This is the first lab that you need to order, because you want to figure out if this is PTH mediated or non-PTH mediated. And PTH mediated means that if your patient has hypocalcemia, at the same time your patient has hypoparathyroidism or pseudo-hypoparathyroidism. And non-PTH mediated, if you have a low calcium level, and at the same time, you're going to have low vitamin D or vitamin D deficiency, chronic kidney disease, or low magnesium level, pancreatitis, medications, that we talked about it before. So always make sure that you report corrected calcium. Make sure that you correct for the albumin. Make sure that your patient does not have severe acidosis or alkalosis, which both, as we discussed, can change the calcium level. Always order PTH, vitamin D, phosphate, and magnesium at the same time. If your patient has severe hypocalcemia, just make sure that your patient does not have prolonged QT interval. Can increase the risk of arrhythmia if you're not aware of prolonged QT interval. And if your patient has prolonged QT interval, as we discussed, the treatment is IV form of calcium. Tetany and neuromuscular irritability or hallmark signs of severe hypocalcemia, and EKG monitoring is really important. And treat acute symptoms first and then correct on the underlying cause. Okay, so let's shift gears to hypercalcemia. So hypercalcemia is often an incidental finding detected on lab work completed for other reasons. When calcium levels rise above 12 milligram per deciliter, patient typically present with clinical signs and symptoms. Regarding the causes of hypercalcemia, we can have two different categories. First one is parathyroid mediated. In this group, we have three differential diagnoses. The most common one is primary hyperparathyroidism. The second one is familial hypocalciuric hypocalcemia. And the third one is tertiary hyperparathyroidism, the setting of chronic kidney disease. And non-parathyroid mediated is if the patient has hypocalcemia's malignancy, we'll talk about it later, and granulomatosis disease and endocrine disorders in this category. We do have severe hyperthyroidism, adrenal insufficiency, acromegaly, pheochromocytoma. Some medications can cause hypercalcemia, for example, thiazide diuretics, lithium. Vitamin detoxification can cause hypercalcemia, immobilization, and also rhabdomyolysis. These can cause all those are like a differential diagnosis of non-parathyroid mediated hypercalcemia. And what does it mean, parathyroid mediated and non-parathyroid mediated? Basically, if your calcium level is high, PTH is supposed to be like low, really low or suppressed. So if your calcium is high and your parathyroid hormone is suppressed or very low, we can say that your patient has non-parathyroid mediated hypercalcemia. But if your patient has high calcium level, and at the same time, if your patient has a high parathyroid level or even normal parathyroid level, we call it parathyroid mediated. And if the PTH is normal, do not assume that, okay, PTH is normal and my patient has non-parathyroid mediated. No, this is not true. We call it inappropriate to normal PTH level because, again, PTH is supposed to be suppressed or really low if the calcium is high. And this is true for any hormones in our body. For example, if your thyroid hormone, if your free T4 level is high, your TSH, which comes from pituitary gland, is supposed to be suppressed or low. And this is exactly the same for calcium. If the calcium is high, PTH is supposed to be low or really low or suppressed. If not, or even if the level is normal, we call it inappropriate to normal PTH level. So, and also this graph can show the same idea. If you have low serum ionized calcium and low PTH level, we have primary hypoparathyroidism. If your calcium is high and you have a low parathyroid hormone, we have non-parathyroid mediated. And if everything is normal, so basically your patient has normal levels. And if your calcium is high and parathyroid is high, we have primary hyperparathyroidism or parathyroid-mediated hypercalcemia. And if your calcium is low and your PTH is high, we call it secondary hyperparathyroidism, mostly in the setting of renal dysfunction or nutritional severe vitamin D deficiency. Okay, basically this is the same idea. This is like the serum PTH concentrations according to the serum total calcium concentration in various disease. The normal range is shown in the white box, and the sigmoid curve, which is like a green star, is derived from a calcium citrate infusion protocol administered to 38 normal subjects. Serum PTH and calcium values are low in hypoparathyroidism. You can see in open blue boxes, and high in primary hyperparathyroidism. You can see in blue squares. And the serum calcium concentration is high, and serum PTH is appropriately low in patients with non-PTH-induced hypercalcemia of malignancy. You can find it in red circles. Basically the same idea as I mentioned. Okay, so let's talk about differential diagnosis of parathyroid-mediated causes of hypercalcemia. We had like three differentials: primary hyperpara, FHH, and tertiary hyperpara. In terms of primary hyperparathyroidism, is often detected as asymptomatic hypercalcemia routine screening, and maybe suspected in patients with nephrolithiasis. Usually, if someone has multiple kidney stone, one of the differentials is a primary hyperpara. And you need to confirm hypercalcemia by repeating calcium and measure intact PTH. And diagnosis is based on elevated or inappropriately normal PTH in patients with hypercalcemia on two occasions with more than 2 weeks apart. And the most important differentials is FHH if PTH is only mildly elevated. And when we do genetic testing, because primary hyperpara can be part of genetic disorders, and but thankfully, most of the patients with primary hyperpara, they do not require genetic testing. But if you have a patient diagnosed with primary hyperpara, age less than 30, if your patient has a strong family history of primary hyperparathyroidism or atypical parathyroid adenoma, now you can think about genetic disorders such as MEN type 1, MEN type 2A, or hyperparagia tumor syndromes. Those are the syndromes that are associated with primary hyperparathyroidism, and you need to send your patient to genetic testing to just make sure that this is only primary hyperpara and is not associated with other genetic problems. About the familial hypocalcemic hypocalcemia, this is really important to differentiate FHH to primary hyperparathyroidism because of the treatment. So if your patient has FHH, you can just tell patient you do not even need the follow-up, and you have these genetic disorders, and basically you're going to be okay for the rest of your life. But if the patient has primary hyperparathyroidism, the main treatment going to be surgery. So just imagine if you send your patient with familial hypocalcemic hypocalcemia to the OR for a surgery, it's going to be a disaster. So it's really important to differentiate FHH from primary hyperparathyroidism. Basically, FHH is autosomal dominant. Patient has long-standing and mild hypercalcemia. And it's important to understand that the PTH is usually normal or mildly elevated, and urinary calcium going to be low. This is like a key feature distinguishing from primary hyperparathyroidism. We usually check 24-hour urine calcium, and we measure calcium creatine ratio, and based on that, if the level is like we cannot decide, we send patient for like a genetic test. And family history is really important. Always ask a patient that any of your family member, like parents, siblings, that they have hypercalcemia or not. But again, it's really important to differentiate these two entities from each other. And just a quick tertiary hyperparathyroidism is a setting of prolonged kidney problem. We're not going to talk about this here. But just remember, if you have normal or high PTH level in the setting of high calcium, you have three differentials. And the most common one is primary hyperpara, and it's really important to rule out FHH before sending patient to the OR for the surgery. Okay. And so let's discuss about the non-parathyroid mediated causes of hypercalcemia and what does it mean. Again, if your calcium is high and your PTH is suppressed or very low. So in this category, we have hypercalcemia of malignancy. In this like a malignancy, we have like three different causes that can cause hypercalcemia. So the first one is PTH-RP mediated in the setting of squamous cell carcinomas, and we can have bone metastases with osteolysis in the setting of breast cancer, multiple myeloma, lymphoma. And also we can have 125 dihydroxyvitamin D overproduction. Some lymphomas can cause this. We can have granulomatosis disease like sarcoidosis, lymphoma, or other granulomatosis disease. The mechanism is increased external conversion of vitamin D to active form. And medication, always check a patient's medication list. If someone taking thiazide diuretics, lithium can cause hypercalcemia with low PTH level. And also milk alkali syndrome. Patient has hypercalcemia, metabolic alkalosis, and acute kidney injury, and caused by excessive intake of calcium, especially calcium carbonate or TAMS, especially if the patient has prolonged peptic ulcer disease. And if they take too much TAMS, patient can develop milk alkali syndrome. In the past, they used to treat peptic ulcers with milk, and so milk has calcium, and a patient can at that time develop milk alkali syndrome. That's why they call it milk. So milk is part of the syndromes. That's why they call it milk alkali syndrome. Okay, this is another slide about the hypercalcemia of malignancy. If in some cases, for example, about like 80% of the cases, we do have excess PTH-RP. So in the setting of breast, lung, and squamous cell carcinoma, carcinoma, I'm sorry. If like really rare cases, we do have increased PTH hormone, and in lymphoma, we can have increased 125 dihydroxyvitamin D. And some tumors, like cancer, they can directly attack to bone, and the breast, lung, and some like multiple myelomas can cause this type of hypercalcemia. And it's really important to know what you're dealing with, because sometimes we do see some students, some like a resident, they order PTHRP for patients who already have elevated parathyroid hormone. So, so first step is always distinguish between parathyroid mediated and non-parathyroid mediated. And if you are dealing with non-parathyroid mediated, you can order PTHRP to rule out malignancy, a related cause of hypercalcemia. But if you are dealing with parathyroid mediated hypercalcemia, it doesn't make sense to order PTHRP. Okay, about the clinical manifestations of hypercalcemia, is like a hypocalcemia is really important to understand that if your patient acutely develop hypercalcemia or not. And also the rate of rise in the serum calcium concentration is important. We do have three categories: mild, moderate, and severe hypercalcemia. For mild hypercalcemia means that calcium less than 12 milligram per deciliter. Usually patients are asymptomatic. Some like fatigue can have accompanying of constipation, depression. With moderate hypocalcemia, if the calcium is between 12 to 14 milligram per deciliter, they do have more symptoms. For example, polyuria, polydipsia, dehydration. And if they develop severe hypocalcemia, means calcium more than 14, they have more severe signs and symptoms. So the famous mnemonic is bone, stone, groan, and moan. So means that like a bone pain, kidney stone due to increased urinary calcium excretion. They can develop gastrointestinal symptoms, for example, nausea, constipation, and mental changes, for example, confusion, fatigue. Okay, it's really important to, again, like hypocalcemia, just make sure that you order EKG for your patient because, and also the hallmark of EKG change in hypercalcemia is a shortened acute interval, and it's mainly due to shortened ST segment. So other possible findings are mild PR prolongation, YQRS, and sometimes J-bone elevation. It's really important to understand that hypercalcemia sometimes can mimic MI on EKG because of STT wave abnormalities. Be careful and pay attention to QT interval, distribution of changes, and cardiac biomarkers. So those can help you to prevent misdiagnosis. So again, hypercalcemia can mimic MI on EKG. So regarding evaluation and treatment, my longest-standing and asymptomatic hypercalcemia, usually calcium less than 11, suggests usually primary hyperparathyroidism or FHH. And clues for FHH, if the patient is young, positive family history, or has like no symptoms. And if your calcium level is like high, more than 13, is uncommon, is primary hyperpara, is more like a typical of malignancy-associated hypercalcemia, and which usually has a rapid rise, more severe symptoms, and higher calcium levels. In terms of management, for mild to moderate hypocalcemia, avoid aggravating factors. For example, stop if your patient is on a thiazide diuretic or lithium, stop those medications. And just make sure that your patient's volume, they give like enough volume to your patient and avoid volume depletion and avoid prolonged bed rest and just make sure that you do not tell your patient to stop taking any calcium through diet because if your patient has like a low vitamin D and like stop calcium from diet can increase parathyroid hormone and can worse the hypercalcemia situation. But definitely we don't give high dose vitamin D, but we do not stop everything. So in terms of severe hypercalcemia, it's really important to hydrate our patient. We can give IV isotonic saline, and we can give subcutaneous calcitonin for 24 to 48 hours and not more than that. And we can start the bisphosphonate. Usually IV bisphosphonate is hyaluronic acid or reclast. Just remember, bisphosphonate takes about 3 to 4 days to kicks in, and so in the meantime, we can make sure that your patient get enough IV fluid, and also you can fill this gap with giving calcitonin to your patient. As a last resort, we can use dialysis with lower zero calcium dialysis, and also you can have a conversation with your nephrology colleague, and also we can use peritoneal dialysis with a slower. And this is a specific approach in terms of for the treatment of hypercalcemia. If you diagnose your patient with hyperparathyroidism, you can either do a parathyroidectomy or monitor patient. So when to monitor, when to choose to do surgery is going to be like another topic. But the mainstay is like parthyroidectomy. And the caveat is if the patient doesn't meet criteria for surgery or basically it's like a lot of comorbidities that make surgery kind of like difficult for the patient. But it's going to be like a different topic. If your patient has hypercalcemia in the setting of granulomatous disease, like lymphoma, sarcoidosis, um, low calcium diet, you can treat your patient with a steroid, usually prednisone dose of 20 to 40 milligram per day. And if your patient has FHH or familial hypocalcemic hypercalcemia, we do not treat those patients, and we let patient know that you have this genetic problem, and also we tell patient to do not let anyone touch your neck and don't go for surgery for mild hypercalcemia. And a quick take-home messages. So definition is if the corrected calcium more than 10.5. So again, I'm gonna emphasize again, always report corrected calcium. And causes PTH. The first thing that you have to order after a diagnosis of hypercalcemia is parathyroid hormone because you want to know what's your next step going to be. Either your patient has PTH mediated or non-PTH mediated. PTH mediated like primary hyperpara, FHH, or tertiary hyperparathyroidism, and non-PTH mediated malignancy, vitamin D toxicity, drugs, those are the differential as we discussed. So EKG finding is short QT intervals, really important to monitor patient. And most common cause of hypercalcemia as an outpatient setting is primary hyperpara, and inpatient setting is unfortunately is malignancy. And again, hypercalcemia and malignancy is rapid and also severe hypercalcemia, usually more than 12, 13 milligram per deciliter. And always make sure that your calcium level back to normal before treating underlying causes. And that concludes my presentation. And thank you for your attention. And I hope you enjoyed the presentation. Just for your information, this is Moraine Lake in Banff National Park, Canada. And I highly recommend visiting and exploring that. Thank you, everyone, and have a great day.